Good afternoon, everyone. We'd like to welcome you to another one of our Lunch and Learns. And we really appreciate everyone coming out today, and also those of you who are in the units who are online. It is my great pleasure to introduce Dr. Janak Patel. Dr. Patel is the director of the Pediatric Infectious Disease Division. And he's also very well known and very accomplished in treatment of pediatric HIV. For many years, Dr. Patel, when women would get pregnant who had HIV, he would manage their care, and actually still does.
Still do.
Shouldn't use that as past tense, although fortunately we don't have to do it nearly as much as we used to. And then manages those babies who are born to HIV-infected women, and in the event that children actually are infected, provides care to them. And so he's here today to give us an update on progress made in the prevention of mother-to-child transmission. So without any further ado, Janak Patel.
Thanks, Phil. Thanks. So I guess I do this lecture every few years. So some of you, if you work long enough in TDC, you probably would have heard of. How many of you here, at least in this room, have heard from me before? Good. So everybody's new. That helps. So, you know, as Dr. Kaiser mentioned, we run a comprehensive mother-child HIV clinic. And that gives us opportunity to get involved with mother's care that really impacts the baby, right? So we learned long time back, about 25 years ago when I started this program, that starting with the mother in a very specialized approach with our social workers who really are much more attuned to the perinatal issues, the OB/GYN issues, the special insurance issues. There are very unique features about pregnancy that you really have to work as a team. And I'll show you at the end what kind of people have been working with us. But, you know, this is the context in which I think I'm going to talk today. It's mostly about our experience as well as looking at some guidelines for prevention. So I think my focus is clearly about prevention. Okay, so, and again, I have no conflicts to declare. So if you look at this slide, a couple of years, well, I hope I can use the pointer, I probably can't. So if you look at how perinatal HIV or pediatric HIV cases were being encountered in this country, you know, we started seeing them from early 80s. And really they peaked around between 1991 and 93 in this country. And soon after that, we had a dramatic decline, right? Which right now in this country, we have less than 50 new HIV-infected patients a year, the entire country, okay? So it's considered, now you can count many success in HIV field, right? This is considered the best and the first example of what HIV care can do, is prevent transmission, right? And you know, what we learned in this lessons with this program, finally are translating to the adult side where you're talking about now pre-exposure and post-exposure prophylaxis, right? It was the bread and butter for pediatrics. So you can see soon after 93, we had dramatic decline, and obviously that is from testing and treatment, and which is what we more are going to talk about. In the state of Texas, we probably have about 4 to 5 cases a year. Could be a few more. Some are not diagnosed in time, and they show up a couple of years later. All right, so this slide shows you the number of women annually that we have been evaluating in our program. And you can see that it does go up and down, right? And early in the program, I wasn't seeing every pregnant woman, okay? But it became very clear when the prevention efforts were being slowly, you know, we are becoming aware that we better start seeing pregnant women as a programmatic, you know, approach. So we did, you know, begin in basically early 90s to do that. And, you know, we have peaked, our highest numbers annually have been 36, achieved twice in 2000 and 2010. But in most years is in the upper 20s, and we often hit the mark of 30, okay? So it's a stable number, I would say. It's not rising year by year, and there are many reasons for this. I'll tell you one of the most important reasons right now, which does not apply to your TDC population. We have the highest record in this country of number of women choosing tubal ligation for family planning. We have more than 50%. Okay. By the time they're in the third pregnancy, we have close to 90% of women doing real family planning. So that's because of the approach we take about women, wanting to focus on their HIV care and existing children they have, because HIV care needs a lot of attention and discipline. So we don't have a growing population of women of childbearing age. And again, we have national trends which have also impacted the number of new cases. But we've seen flattening long time back. Now, if you look at just the state of Texas data and look at the rates from 2005 to 2014 in terms of new diagnosis by mode of transmission, the pediatric, you can see, is, just hugs the line of zero when you compare the adult cases. Now, MSM cases obviously are still rising, but, for us in pediatrics, we're talking about heterosexual, by and large, the women who get pregnant, that is their risk. And that has remained steady and maybe some decline lately. Okay, if you look at the HIV diagnosis rates by race and year of diagnosis, you can see that the African American population is still the largest proportion, and slowly we have some control over that as well. And if you look at what we are seeing in our program from the beginning till December last year, and look at the racial ethnic mix, you see the African American population is about 62%, which is the largest. Our second highest is white, and third is Hispanic. And this really reflects pretty much perinatal, experiences across the state. So the cornerstone for prevention really starts with testing and then prompt treatment. So in order to facilitate testing, we have to have laws, right? Physicians if you leave it to the normal medical system and physicians and nurses to decide who to test, we are not very good at it. Okay. Everybody's supposed to be tested for HIV at least once, right? If you're in a sexually active age group, how many of us have been tested? None. So a lot of obstetricians early on in the game were also picking and choosing their patients, thinking, oh, my practice doesn't have HIV, or I got this kind of patient, is not at risk for HIV. If I test her, she will feel offended. So we have a lot of people not doing it. So we need a state laws, and so the state laws really give you no choice. You really have to offer the test. The individual patient can decline. So we got this law, which was recently changed with effort from couple of my colleagues as well. So right now, this is what we require in this state. By the way, it does vary from state to state. Okay, so this matches the CDC recommendation. So we do our first HIV ELISA for the screening purpose at the very first encounter. Okay, and this can be inpatient, outpatient. I can tell you, we have hard time fixing this certain mindset, and this is within UTMB. We have this policy, and now we made it in a state law. There was a time doctors who refused to test. I haven't seen her in my clinic, so if she's in the hospital with labor, they don't test them because the policy was in the clinic. And so sometimes they come to the emergency room with no prenatal care, right? So we have to test them, no matter where they are. And that applies, of course, in the TDC system. If you got a pregnant woman, make sure they have been tested. Now, I know HIV test is offered to every inmate, right? And they can refuse testing, but if a pregnant woman refuses testing, I would strongly urge to get more people involved for counseling purpose. All right, so the next thing is the repeat test, which formerly used to be at delivery only. We have pushed it a little bit up in third trimester, and our preferred time point, at least within our OB practices, is 30 to 34 weeks. The reason was that, if women were going to convert during pregnancy, that means they're getting infected during pregnancy, we don't want to wait till delivery to find that out, right? Because if you find it out at least a month or two before, you can counsel them, give them access to medications, and do something about it. So the laws also states that if the third trimester test result is not available to you, please test them at delivery. And hearsay is not allowed. A patient is not allowed to say, well, I was tested, I was negative. You have to have real lab proof, and it is in the law that you must see the original result. So this is the law, and by which most hospitals and clinics now practice. I still encounter patients every year who have not been tested according to this guideline. Okay. I also encounter patients who still have not been tested despite seeing physicians. It's rare. Every year I encounter about one patient who has seroconverted in pregnancy. Okay. So this two testing rule is quite beneficial. So just to remember that. Sometimes in TDC system, they are in your, they may have been tested in the beginning, and, just like all inmates, I know they have no more exposure in, hopefully in TDC to say, have they been reinfected? But you need to consider, because the law doesn't give you that exception, okay? So the lab diagnosis obviously occurs through screening serology, and I'll talk about the older and the newer, testing strategy. And the ELISA as it is actually quite sensitive and fairly specific, okay? So it's more than 98% sensitive and more than 98% specific. But because even that 1 to 2% false positive is not an acceptable, way to diagnose people, we do follow-up testing, that is confirmatory testing, and at UTMB is Western blot, but I'll show you the newer testing strategy. So this is, hopefully you are documenting all that you've seen confirmatory test. What we encounter very often, if I have time I'll talk about it, is women who are tested close to delivery or sometime in pregnancy, and the Western blot is indeterminate, and we have to then work with that, right? So this is another part of the law, which is about treatment of the exposed baby and, of course, the mom. So if you are doing a test, the law states, and test at delivery, that you must have the result available within 6 hours of collection, and the law requires this result to be released without confirmation. And I have seen kids and others have seen it, which led to some changes here, is that in the past, the standard practice was that if ELISA was positive, it will not be released until the Western blot result would be back, which takes a couple of days, right? So ELISA may be done every day, several times a day. Western blot is done once a day on weekdays, and sometimes they even batch it. And some hospitals send it out. Some hospitals, in fact, used to send out ELISA itself. So it had no purpose to be tested at delivery. So the law now dictates that you must do the test in-house, and result must be released to the physician within 6 hours. Confirmation is not required. Of course, physician has to work with that kind of scenario as to what do we do. But you don't want to delay some discussion around a possible positive case. The other thing that the law requires is that if the mom is in labor, she must have IV AZT as soon as possible, if indicated. By the way, the national guidelines now give you options not to give women intrapartum therapy with IV if they have had undetectable viral load in the last month of pregnancy. So we often don't do it. It also dictates that newborn must get post-exposure prophylaxis, which is 4 to 6 weeks of zidovudine alone in the simplest case where mother was properly treated and controlled. And that treatment has to begin within 12 hours. And this is again a logistic nightmare. Because some hospitals have not stocked zidovudine, in their formulary, in their pharmacy, because they rarely see 1 or 2 cases a year, or some have not seen one case for years, and they don't have it. So where you deliver is very important. You must know that local hospital has it. So the law requires hospitals to have it, but not every hospital has stocked it. Also, when the babies go home, they have to continue this therapy for, as I said, 4 to 6 weeks. So continuation of that therapy, again, is logistically challenging because these babies may be discharged home in the evening or on the weekends, and they go to a local pharmacy, and the pharmacy doesn't have it in stock. If they order it, it may take 2 more days to get it. So this is something we have to solve as an issue. So at UTMB, we have a contract with CVS Pharmacy next door to us, and our residents or the nursing staff or the pharmacy staff physically drives there, picks up the medication to give to the baby for discharge purpose, okay? Because our inpatient pharmacy right now does not have license to prescribe medications for outpatient prescriptions. So I'm just mentioning a few issues that are important logistically in terms of getting things done. So you must have a good strategy around this. And then, of course, you must follow up the baby for diagnosis. Now, to get these results in 6 hours, some institutions have used this so-called rapid antibody testing kit. There are a couple of them now. And especially if they have low volume deliveries in terms of how often they have positive ELISA, or how often they have women with previously undone test, they may use this one. But at UTMB, if you do any test at delivery, it's basically run around the clock. We have a new ELISA platform that can do several types of several types of serologic testing in a run. It doesn't require a machine to stop and switch over to ELISA platform, okay? So because of that, we don't have this so-called rapid test kit because we do get results back in 6 hours. That is our institutional rule, and we do get a phone call directly from the lab. Some of you may have seen this. How many of you have seen this? Probably not in the TDC system. All right, so I'll skip this scenario. Let's look at briefly this particular slide on the seroconversion and viremia and all that. That will make it easy for you to interpret the newer testing algorithm. So soon after someone is infected, you get this primary acute retroviral syndrome, which is primary infection. And some patients actually have symptoms here. They look like, having a monotype illness, sore throat, lymphadenopathy, rash, fatigue, fever, often not recognized as HIV unless you belong to a high-risk group and you have an experienced physician. Most people really don't get diagnosed in this period. Now, during this period, the viral load, you can see this viral load here, does shoot up quite a bit. And I've seen some patients, people have reported close to 500,000 or even more copies. And over the next couple of weeks and few months, the body's immune system kicks in and does bring down the viral load. And actually, in our HIV clinic, where we diagnose women just because they were been tested, we have 15% of our HIV-infected patients confirmed with Western blot who are actually undetectable by viral load. So they are elite controllers. So we do see that. If you look at the ELISA, how quickly it becomes positive, it is this solid line here, the green line. So it starts to become positive in between 2nd and 3rd week, right? And by 5th and 6th week is very strongly positive. And if you look at the Western blot, it will actually lag behind, and it's not here, but you can see this here, this black bar here. It starts to be positive. It lags ELISA testing by about 2 to 4 weeks. Okay, so especially in this seroconversion phase. Now, this is very important for us because we do see a fair number of indeterminate tests where we have to make a quick decision about what to do with this pregnant woman with no confirmatory test available to us, right? So it is in our algorithm as to how do we interpret this and where are we with Western blot conversion? How can viral load help? And how quickly is viral load done? It's not done around the clock. We batch it. We do it about twice a week. So it's not something that's going to help us very much on this spot. Okay. Now, in order not to miss this population here by conventional testing strategy, which is the ELISA antibody alone, we now have developed a new assay. It's a 4th generation test, which actually has been used for about 2 years now in other institutions. We have made a request to get this brought on here. And I know Phil is aware about it, and I have had several communications that tell me, it's very soon, it's very soon, it's very soon. I don't know what the reasons are for the hold up. I have to get back to them. Maybe we should do it together. So, during this phase, as I said, the viral load is high, but if you also do an antigen test, which is a piece of the viral protein, you can also detect it, right? So it's that top line, the second line here, this bar is P24 antigen. So the newer generation assay and I'll come back to this slide and explain that a little bit more. So if you have an indeterminate test, using Western blot as your confirmatory test, you may have an indeterminate test result where the Western blot is not fully positive. So you have two possibilities. One is that it's either false positive, or it's an early HIV infection where you don't have enough antibody for Western blot to become positive. Remember, I said first thing ELISA becomes positive, and positive Western blot lags behind by 2 to 4 weeks. Okay. So the idea is that if you were using this scheme, you just retest them in a month, and the antibody test will be stronger. And if it was indeterminate before, the Western blot would now become fully positive, and that's what's required to repeat it in a month. And you can also do viral load if you are urgently in need of knowing that state, whether it's early infection or false positive. You can do it, but in many cases, if they are early in pregnancy, first trimester, repeating the test, I think, makes more sense. But many of our patients do get viral load done. So the fourth generation assay, which we are not using in our system, and Phil, correct me, in your TDC system, if they're tested in other places, are they using the fourth generation or third generation? Any one of you aware? Dr. Kaiser, do you think? If you offer HIV test in your other outlying clinics, it's still Western blot, right? Yeah. What I'm saying, if you test them in your other outlying prisons, all the HIV test comes here for testing, right? So it's not like they're using some other assays elsewhere. No. Okay. So glad to know, because I have never seen a fourth generation from TDC either, because it's all at UTMB. All right, but you will see these kind of results. Maybe patient comes in from an outside institution where now majority of them actually have switched over, okay? It's called fourth generation test, which combines the antigen, the P24 antigen, and the antibody in order to catch people in that acute retroviral syndrome phase. That means seroconversion. Okay, and the transmission risk actually may be higher, although in perinatal setting that's not proven. But we know in adult setting, highest risk of transmission is during that stage when there is a lot of viremia. Okay, all right. So in order to catch people in that seroconversion phase, we are now recommending the fourth generation assay. So if you are positive, this is how it works. By the way, in the fourth generation assay, you will not see a Western blot. Okay. And some people really want to see that, and you will not see it. So this is what happens. So it's an ELISA test that is done twice. So the first ELISA test on this side is a combo test. It includes the P24 antigen and HIV1 and 2 antibodies all combined in one. If it's positive, we don't know which is giving you positive signal. They're not going to tell you that. It's antigen or antibody, okay? So if that signal is positive, then you do what's called a differentiation test. Is it HIV1 or HIV2? There are two types of HIV. HIV1 is the predominant virus in this country, and HIV2 is less than 1% of all HIV we see in this country is HIV2. But because it's a different ELISA system, it has a different false positive and false negativity. So if you are positive by a combo test and you are positive from this differentiation test for HIV1, then they say it's confirmed. You have HIV1 infection. No Western blot needed. No PCR needed, just to confirm that, okay? I'm still a little nervous about occasional cases where people may not know that you've got to do extra things. And if they are negative for the combo test, there is no further testing done, right? Now, if you are positive for HIV2 and negative for HIV, that means you have HIV2 infection. Now, I've seen a few cases here that are all imported. I saw one West African woman and one woman from India. Those are the two only cases I've seen. Okay, then you can have dual infection, HIV1 and 2. Again, much more common in West Africa. That's where HIV2 is found, and the Indian subcontinent. And if you both are negative, even though the initial combo test is positive, you are not going to tell the patient you don't have HIV. You are going to do what's called, PCR-based differentiation. So you can do nucleic acid detection, viral load, any molecular test is required. And this is where things fall through the crack in the fourth generation test. That this is a add-on test that patient has to be brought back. And people misunderstand the way the results are reported. So different labs report things differently. They'll report this result first, and you think you got your diagnosis. Then another result comes back, and you don't know what that means. So I've seen people who are positive told they are negative, and I've seen people who are negative and told they are positive. So CDC has this complex diagram where if you are nucleic acid test is positive, clearly you have diagnosis, but if it's negative, it is false positive. But if you look at this test here, if it's positive, you must still undergo PCR-based testing anyway. Then you have elite controllers who are undetectable. So, you got all these issues around, are we perfect with the new test? We are not. But we should understand what makes it false positive. Because remember I said 1 out of 15 patients in my clinic. No, not 1 out of 15. 15% of my patients in my clinic are elite controllers with fully positive Western blot, undetectable viral. Okay? All right. So I always have a little bit of my concerns, but I think most of them will be HIV 1 into differentiation test positive. Okay, let's move on. So in order to do prevention, you must make sure your labs have a policy for testing in-house. Now let's talk about consent. HIV consent is a very simple process. Again, this is very important for pregnant women and at delivery where things are going at fast pace, right? And HIV, which group do you think gets tested most often in this country? It's pregnant women, right? Every pregnant woman is offered this test in this country. Half of this country's population in sexually active age group is tested because of pregnancy. And so consent is a big deal in an OB/GYN clinic because every patient gets tested twice. So there was a time when obstetricians, as I said, would not offer the test because they were uncomfortable with counseling and all that, right? Then the laws made it much more of a requirement. Then even then they said there we have a barrier for testing. I did not have a consent form at hand, right? Or patient signed it and we lost it. Stuff like that. And, some were excuses. So right now, for several years, and the state law now accepts this in the new testing law, that verbal assent is adequate. All right? You don't need a separate HIV consent form. Consenting for medical care includes HIV test. Okay? That's number 1 rule. If the patients are denying the test, then you should document it in medical records. The patient declined the test and write down a reason. You are supposed to ask the reason. Okay? All right. So, it's an opt-out strategy that we recommend. And the opt-out strategy begins like this. Okay? So, normal consent process is like you tell the patient, I would like to test you for HIV. Can I test you? Right? And the patient may think a little bit something in my brain and say, no, I don't think I need a test. And you move on. Okay? In opt-out strategy, you start from the opposite end. You say, you put HIV in the testing in the context of all of the things you are doing. So you say, you are a pregnant woman, and while you are pregnant, we do hepatitis B, syphilis, HIV, everything. And you just say, is there any reason we should not be testing you for this? Don't single out HIV. It should be part of normal care. Okay? And when you ask for a reason why not, then they cannot come up with a good reason to say no. If you don't ask for a reason, and it's an opt-in strategy, they don't have to tell you anything. Okay? Now, declining HIV test is number 1 risk factor for being HIV positive. All right? So that's a red flag. So we've had some patients in at least non-TDC system, and I've known at least one TDC patient who refused to be tested. And often with a backup counseling, coming to Dr. Kaiser or coming to see us, I have never had a patient say no once they have seen me. All right, so it's important to use additional resources to get people tested. Pregnancy is a very important stage where a lot of personal freedoms and choices, I think we should be very careful about, not paying too much attention to that because it's really about perinatal transmission. All right, so what are the treatment options for pregnant women? So before we can talk about it, let's talk about just transmission. When does it really happen in this entire stage of pregnancy, delivery, and postpartum stage? So if you look up here, if you have hypothetically 100 pregnant women, they're all HIV positive, and you don't do breastfeeding, then you have 17 plus 6 plus 2 plus 1, about 25% of pregnant women will transmit the infection, okay, without any intervention. Some say, oh, that's not too bad. Some say that's a lot, right? Depends on what you consider is how much is too much, okay? So 25% in my experience is a lot, okay? And if you allow breastfeeding to continue, you add another 10 babies. So you get 36 babies out of 100 that will be infected. So about 30% of total transmission occurs also postnatally if you allow breastfeeding to continue. So we try to control this setting, postnatal breastfeeding, and then we take control of HIV care in pregnancy intrapartum, then we have very good result, which is close to 0%. I'm not going to talk too much about breastfeeding and how we can still allow it in certain setting by treating the mom or the baby, because it's a very difficult process where many women do not have consistent HIV care once they deliver a baby. All right. So the reason why, we have this strong interest in giving treatment and preventing transmission is because of this original trial done in the early 90s and published in 95 actually, but we were already practicing in 94 because we are aware of preliminary results. Was a placebo-controlled, randomized, double-blind trial where about half of the women got AZT monotherapy and the other women did not get anything, okay? And if you look at, and what they got was AZT monotherapy also during prepartum, and then intrapartum got IV infusion, and postpartum the baby got 6 weeks of therapy. So we had this package, and if you did that package, the risk of transmission came down from 25% in placebo to about 8% in the treatment group, right? That's about 75% reduction. Huge, huge news. So people immediately moved on to using treatment in pregnant women. And so as you know, right now we don't use any monotherapy for any group of people, right? But when I ask this question often to residents and students and even some physicians in the community, they come back to this original study. Oh, I think you give AZT in pregnancy, right? No, I say we do more than that. We give full heart. Okay, so I was part of the CDC Pediatric Spectrum Disease Project for quite a while until we were so successful that CDC stopped funding perinatal programs actually altogether. So if you look at how many women were getting monotherapy, combination therapy, and all that over time in state of, I think this was Texas, although I have the country data as well. So the monotherapies, this group, the blue, it came down gradually, right? And then the combination therapy increased. But it was within 1 year actually of doing this monotherapy study results coming out that people already were changing the standard of care in adult side to dual therapy in the beginning and very quickly to through 3-drug combo, which is now the backbone of HIV treatment, which is HART. All right. So what do the national guidelines recommend right now for pregnant women? And these options that we have keep changing. Okay. Now, in our practice, we don't want to change too often, too quickly, without knowing the implications. Number one rule for us is our system broken, right? Are we still having transmission? Are we having problems with compliance? Are we having problems with toxicity, right? So we always look at our local experience because these guidelines change often, and I try not to get confused. But it does allow me to look at it and say, yes, I can use this, okay? In addition to what I'm also very comfortable using. Because pregnant women want to hear your stories. Have you used this before? Does it hurt, harm? And a lot of times we don't have data in pregnant women, even when they put them in the guidelines. All right, so this is actually for perinatal prevention. So, the initial part is the 2 NRTI backbone. In the preferred regimen, you have 3 options. One is abacavir-lamivudine combo, but you must have the HLA genotype done, right? We have no time in our pregnant women. Most of them are presenting with testing. By the time they see me, is the second trimester, right? If I were to do that test and then wait for next time to come back and start abacavir, it's not sensible. So unless they already had this test done before coming to see me, we may use that. Some of these women are already on this therapy. We may not change it. But very few pediatric centers are using this as the initial drug of choice. But it is allowed. It's a preferred regimen. Then we have the backbone that consists of tenofovir emtricitabine, and that is really what now we use in many patients. We have enough information on overall safety and efficacy on this particular combo. The only problem is that if you know in adults, you have problem with demineralization of bone and of course renal function changes. So people have been careful about using it in pregnant women, especially concern regarding the baby or the fetus. But there have been enough reports now. There have been enough presentations and actually publications reassuring that babies are not really having a lot of renal or bone changes. So I think we now use it without much concern, especially Truvada as part of any combination. Next one is Combivir Combivir, which consists of Zidovudin and Lamivudin. That's really has been the backbone for our NRTI regimen for years, and it actually still continues to be the case for about half of my patients. And so largest amount of experience is with that product. Okay, we don't see much side effects with it actually. The reason why it became less appealing to the adult population was really the anemia, the hematologic toxicity. Frankly, and we have hundreds of patients, and I have many colleagues who are treating pregnant women. We never saw serious problem with it. Again, we are treating them for a short time, I guess. So if we treat them for years and years, we might have that issue. So many of us are very comfortable with it. I have rarely changed Combivir because of any toxicity, believe me. Then the regimen on this page is really the, after you choose the two NRTIs from the previous slide, you add another agent from this slide. So from PI regimen, right now, it's very weird. The only giving preferred regimen, only one choice for PI regimen, which consists of atazanavir and ritonavir, given once a day, is not a combination pill, right? So there is an additional pill. And, we have been using Kaletra in the past, and we haven't changed that. So, because I think we've been pretty happy with that overall. This drug is supposed to be better tolerated than Kaletra, but we have far more information about Kaletra pharmacokinetics and its effect. So, but anyway, I guess some people are using it. We prefer Kaletra only because it's a combination pill. Then we have an NRTI regimen you can also use if you don't want to use PI regimen. And efavirenz, which was a no-no for a long time because of potential effect on the fetus brain development. Now they say that if you are starting therapy new and patient has already gone through first trimester, and that's the usually time many of them show up with referrals, you can start it. And in Britain and some European countries, in fact, is used fairly commonly because it is a fairly cheap drug overall. All right, so the guideline says it can be initiated after first 8 weeks. We often wait till 12 weeks. And the other alternative is to use integrase inhibitor regimen, which consists of raltegravir. Okay. Now, this is very popular in our clinic now. So, Stribild, alvitagravir. So, any of these integrase inhibitor regimen now comes as part of combo with Truvada. So, it's one pill once a day. So, this now becomes part of our regimen if we are not using Combivir and Kaletra. Another alternative regimen, so this is no longer preferred now, this is alternative, is where Kaletra now is slotted, which for us is still among the preferred PI. And if you are using any NRTI regimen, the alternative is rilpivirine. Frankly, this combination which consists of tenofovir, emtricitabine, and the combo pill is called Complera. It's fairly popular in women of childbearing age, okay, because they could get pregnant at any time. And efavirenz, as I mentioned in previous slide, should not be ongoing drug when you're getting pregnant, okay? So you can start it after 8 weeks when the brain development has taken place substantially. So, but again, you would not use it as the preferred regimen. So Complera has been the preferred NNRTI for us. And so in many places not an alternative regimen, is really among your top 2 preferred regimen. All right. So the other problem with rilpivirine is you have to know your viral load. If it's very high, it's not a preferred regimen. So, that's why Coletra-based therapy, PI-based therapy is what we prefer. Because we often don't wait for these results in many of these women who have to start treatment. All right. Then nevirapine is one of those drugs that was available among the first NNRTI to us, and very quickly we found out that pregnant women develop Stevens-Johnson syndrome, which was, systemic disease with skin and mucous membrane reaction with hepatotoxicity. We actually had quite a few patients here at one time, and we quickly learned that was due to nevirapine, and now is not recommended. Unless you're already on it, then patient is already stable on it, you don't have to worry about it. This side effect used to occur much more in women whose CD4 count was more than 200. So they actually were more immunocompetent than immunocompromised. So again, I don't think many patients are on nevirapine anymore. Okay, at least in this country. Nevirapine is a very important drug in the developing world. It is even used for protection from postnatal transmission during breastfeeding. Okay, where women stay on nevirapine-based therapy, or if the mother is not on effective therapy, the infant gets nevirapine throughout breastfeeding phase. So I rarely encounter a patient on nevirapine. But there are some patients walking around the adult side who have had it for years and they continue, and if they become pregnant, we leave it alone. And talking about efavirenz-based therapy, right now, in fact, we have a pregnant woman in the hospital right now who was being treated by a Beaumont physician before getting pregnant and was on Sustiva, which is efavirenz containing, and now she's 6 months pregnant. The question was, should we switch it? We said, no, it's too late, and baby's head looks pretty good and all that. So, she's one of the recent examples of a woman coming in with efavirenz-based therapy. All right. So what if a woman is on non-standard regimen prior to pregnancy? What options do we have? Okay. So again, in general, if a specific combination is not contraindicated, we continue. Remember, we have tons of new medications with absolutely no information of pregnancy. Okay. So we are very careful about not jumping the gun, with all these newer and sexier drugs being available. We go with, as I said, our first rule is, do we have a broken system? Do I have transmission occurring because our medications are ineffective? The answer is no. In general, unless there's a contraindication, we continue. We don't need an indication. We need a contraindication. All right. You can change the contraindicated medications unless resistance limits the option. So we often have a little discussion with pregnant women, and if they want to change, we do it. But in general, we don't change things anymore. There was a time also we were pushing to include AZT to be part of the regimen. Okay, Zidovudine. As you know, Zidovudine is now not even the first line option for adult non-pregnant people. Is not even a second line option. Is probably not even a third line option anymore. Okay, yet it is the backbone of therapy in pregnant women. So you don't have to, bend over backward to include AZT in your regimen for pregnant women. Yet, for the infant, once the baby is born, it is Zidovudine monotherapy. What about C-section? Well, before I leave the medication thing, the only thing I want to mention in this group here is the TDC formulary, right? I mentioned things here that are not available in the TDC. In fact, many of the combinations pills, that are recommended are not available as combination pills in TDC. Good old example of, even Combivir has never been made available there. You have to order Zidovudine separately from Lamivudine. Okay? So, Dr. Kaiser understands that world much better than I do, but this is a little bit of a challenge in TDC system as to which medication I often have to make a phone call and find out the latest formulary issue. And sometimes medications get really delayed for that reason. So C-section was an interesting and important question many years back when we had, either no therapy or we didn't know how to prevent transmission with medications, or the therapies were not as good. So, obstetricians were interested in seeing if delivering the baby by a non-vaginal route, would it help? And it's thought that vaginal delivery is much more stressful. It has more forceful contact, and there's more mucous membrane exposure, bleeding, lacerations, and all that. That C-section might be a safer way to deliver. So studies were actually done. But I just want to show you overall trend. Again, one of the studies I was involved with CDC. And if you look at what was going on from 95 to 2001, 3 things were happening. One is that our HIV transmission rates, which is this triangle line, were coming down, right? Very nicely. And the question was, what was it due to? Was it therapy or was it C-section? And if you look at what was happening during that time, and if you look at these circles, women were getting onto more and more combination therapy, right? But at the same time, C-section rate was rising. Okay, because there was a study published around here. I think I have that here. In 98, there was actually meta-analysis of a couple of retrospective trials, but there was also 2 prospective studies done, where women who were given AZT alone, remember that was the early standard, and when they were compared with AZT combined with elective C-section, that means before the onset of labor, before the rupture of membrane. And if you compare these two, the transmission risk dropped from 6% on AZT monotherapy alone to 3%. So there was further 50% reduction of effect by just combining elective C-section. So it was pretty popular, approach at that time. But remember, these things were happening here. There was not only more C-section, we also having better drugs. So the question is, this study which only used AZT monotherapy, did it have much role? Did the C-section have much role when we were moving to the era of combination therapy? And I can tell you no prospective studies have been done the way these AZT monotherapy and C-section studies were done. So everything is retrospective. So we looked at the national database that was available to us, and we looked at vaginal delivery versus C-section deliveries and rates of infection or no infection. Okay, so if you had no therapy, it was close to what we were expecting, about 22% transmission, no matter how they deliver. See that? That means if you are not on treatment, it really doesn't help to have C-section. Okay, because that is again another thing. Our OBGYN people want to rush in. Well, this woman just came into the hospital, no prenatal care, is HIV positive, should we do C-section? All right. Because this previous study, it has to be combined with AZT at least for that to be beneficial. Now, what if they had monotherapy? We did have some change from 8.1% to 6.77. Not as good as the prospective studies, because this retrospective study we are doing is combination of people on late onset of therapy and things like that. When we didn't know the indication for C-section in many of these cases. So by the time you move on to the 3-drug regimen, you can see the differences between C-section and vaginal delivery have disappeared, right? So this is the basis on which we counsel our patients. And there are other guidelines that say the same thing. Women who are on combination therapy with effective viral control do not need C-section. So we rarely use this now as a preventive modality. In fact, ACOG, which is American College of Obstetrics and Gynecology, has a threshold of viral load of 1,000 copies or more, in the last month of delivery or most recent test offer C-section. All right, next thing I want to quickly move on. I don't know, we have about 10 minutes and I'll leave some time for questions. How do we diagnose HIV in infants? And it's a little different than adults, right? In adults, the testing is based on looking for the antibody, not looking for the virus directly. So, because mother's antibodies go transplacentally from mom to the baby, the antibodies tests in the first year of life are totally useless. Okay? So we go straight to molecular testing, which for the adult side is it comes later on after doing the antibody testing first. So we prospectively follow kids from birth. We get our first test done usually before they go home. And then we bring them back between 1 and 2 months, usually 2 months, because they're on 6 weeks of Zydovorine. I don't want to do a second test on therapy. And the third test is done around 4 months. And if all these 3 tests are prospectively negative, we tell patients that 99.9% not infected. I still don't tell them 100% until I do the antibody test, which eventually, if baby is not infected, has to become negative. Okay? So we prefer to prove that. Now, the reason why, so while, for case definition purpose, viral load testing or any molecular testing is adequate if they are negative by 4 months of age, we still like to bring as many kids as possible for ELISA testing because there are always postnatal events that can be happening. And we don't want to, overlook that, like breastfeeding without telling you, okay? So we like to make sure there is no postnatal exposure that is occurring that is inadvertent. In fact, we have one child, and there have been case reports from Houston and other places. Without breastfeeding, you can still transmit in the family setting to the baby by what's called pre-chewing the food in your mouth, okay, and feeding the baby. How many of you think that happens? You'll be surprised. You'll be surprised. A Houston study of just a survey of pregnant women who are chewing food and feeding 33%. And we started to ask that question. I can tell you, I have so many women tell me, I did it with my last baby. Okay? Or I know my mom did, or my neighbor does it. Please check. Okay? So this is another reason why we want to do antibody testing, at least loss of that maternal antibody, which takes about 1 to 1.5 years for mother's antibody to go away. And then it's nice to have a negative antibody test at that point before letting them go. It's not required by law that they must have a negative antibody test, but the first 3 tests are critical for viral testing. Okay, so I don't want to go too much into, this is just a summary of what we do here. I think we pretty much mentioned that we do have a coordinated program where we work with the adult clinics and my OB/GYN colleagues and ourselves. We do give at least 4 weeks of Zidovudine. We still give them 6 weeks supply. If they run out before 6 weeks, we tell them not to worry about it. This is our success rate. If you break down the group by those who got prophylaxis and those who did not. So with prophylaxis, we have 1.3% transmission. This includes era of monotherapy. Okay? This includes women who got not full, 2 trimester worth of medication. Some got into it even in the last few weeks. Okay? So I'm looking at successes. Even when you include that kind of suboptimal therapy, we have less than 1.3. In fact, among women who have been visiting us while pregnant and have been on therapy, we have 0% transmission for last 15 years. Okay? So you can see how good that can be. If you do not get, prepartum therapy in the mother, we have about 20% risk of transmission. Okay? It could be higher, but we are giving some of these babies postnatal treatment, post-exposure prophylaxis to prevent that piece. All right, so this is our success. I don't want to get into family planning thing, which is a big deal for TDC. Okay? In the free world, as I said, I have close to 50% of my patients signing tubal ligation. We give them options. We tell them it's voluntary, but we tell them why. Family planning is important. It is part of perinatal prevention that we must talk about family planning for the future. Okay? It's in the guidelines, national guidelines. Family planning is part of perinatal prevention. Okay? So, we bring it up almost every visit. We have social workers, counselors, and we work with them. We support the decision. But one of them is that if women know how important it is and how difficult it is to get HIV care for themselves and the baby, and they may have more than one child already at home, and many of them coming from poor, financial background, and many are unemployed, and they have a lot of issues with transportation and all that. They figure with a couple of discussions, visits, that family planning may be good for them. So they have to sign a consent form, right? Which has to be signed at least 30 days before delivery. So we have to coordinate all with the OB docs. Now, in TDC, tubal ligation is not allowed. Okay? You know the reason. In fact, not too long ago, about 2-3 years ago, this became a political hot potato about some family planning. Something was mentioned in the prison system. Okay? So if women don't want more babies because they already have 2 or 3 at home and they want to take care of the HIV, nope, it's not going to happen if you're in jail. Unless there is a medical emergency, then I guess that will get done. Okay? Because they think you are sterilizing women just because they're in jail, right? And that's the problem. So we have enough women wanting it, because I do ask questions. By the way, I see about 3 to 4 HIV positive pregnant women from TDC every year. Okay? One of the challenges we have with TDC is after delivery, what happens with the baby? Okay? And so we work with your baby planners. I don't know if any of them are on the any of the distant sites. And we talk about who's going to take care of the baby. Okay? And we often learn from them, well, is my mom or is my father or somebody or boyfriend? And then we ask them, are they aware of your HIV status? Right? Before you take a baby home and you want to talk about AZT, 6 weeks, come back to clinic for checkers for HIV. Some of them have not told anybody. Okay? So we have these so-called diversion of diagnosis issues, confidentiality issues. We have families who will say, oh, is HIV baby? I'm not going to take that one. Okay? Even with foster care placement, we have issues like that. So we work with these placement issues while, of course, they are pregnant. And we investigate with our social workers. Because sometimes they mention a person, when we investigate, we find they don't qualify. They already have CPS on their back, okay, for their other kids. Or they may have other criminal history and things like that. So they can say anything they want. That doesn't mean they're going to be qualified parents. So we work with all of them through social worker. And every one of these babies, I won't say everyone, often we get CPS involved. Make sure they're properly placed. So I'm going to end this talk by showing you this final slide. And this is what it takes to do HIV prevention in our clinic. It includes a lot of people, from nurse managers, social workers, my adult HIV clinic colleagues, the OB colleagues, and of course working with TDC. We do education within our system, of course research. We help develop policies within the institution, work with the state agencies, work with the local health departments, HIV service organizations in the community, and all that. So it's a good comprehensive program, and we are very proud to have that. So that's the end of my formal talk. Let me now open up the rest of the time for questions. Thank you, Phil. Yes.
HIV-1, HIV-2, is one more virulent?
Well, yeah. Generally, HIV-1 is considered much more fatal illness. Quicker, more severe, more deadly. HIV-2 is considered slower illness, although people do die from it, by the way. Phil, you want to say anything else about it? Yeah. Just considered a little bit less aggressive than HIV-1. HIV-2 is much more restricted to West Africa and some part of the Indian continent. But, you know, people have reported these cases in the U.S. because, among travelers, those who come from that part of the world. So, you know, some of the tests, the viral loads we do are totally useless for HIV-2. So once I have this differentiation test that tells me it's HIV-2, I have to get CDC involved to get my HIV-2 viral load done. The treatment recommendations are a little different. Now, this is just for your background information. You know, once we have that kind of case, we'll figure it out. We had a case last year of an Indian woman in Dallas area, and she was HIV-2 positive, and they initially told her, you don't have HIV, you know, things like that. So, because HIV-1 was negative, they didn't know what HIV-2 meant and all that. Okay, any other question?
I'm interested to know what follow-up is there for the babies, because I know that there are special programs and there is actually the option for adoption. So
sure.
I'm interested in knowing what is the follow-up protocol for those babies that are being adopted to.
So all babies, no matter where they go, family, relative, adoption, foster care. We have foster care far more. Remember, adoption often doesn't happen right away. Some families do go through adoption, and they don't have to be HIV positive, right? I mean, you encounter that all the time. But often there is a time period through which they go through temporary foster care, and then they apply for adoption. That happens more often than, women signing up for adoption right up front. But we have that.
I've seen one case where a mom adopted, the family was just ready to come to the baby.
Sure. So no matter who takes the baby, all of them get follow-up through a designated program. Okay? Okay, this is one rule we have, whether you are in jail or not. No child leaves our clinic or is referred to, or mom is told that you please find a place for your baby to go somewhere. We make the appointment. We find the specialist for them. Not only that, until the baby makes it to that clinic, that patient is mine. Okay? So, we confirm that every one of these babies has made it. And in fact, the largest group of babies going away from our system is Dallas, where Dr. Kaiser first worked from, right? So I send enough babies to the ARMS clinic and all that. But and they know me there. So anytime I have a baby going there, we call. Did you keep your appointment? And, we send them all the lab information and everything. So technically, any baby is either supposed to come back to see us, or is supposed to be at least seen by another clinic where we confirm that they have made it at least for the first visit. We have 0% of loss of follow-up. 0. Everyone is accounted for.
That baby belongs to you and you love them.
Correct. Otherwise they fall through the crack. That's exactly what happens in many places. Yeah. I can tell you more stories, HIV. I give you an interesting story since we have maybe 2 minutes. This is not maybe a TDC story. Although I think the father has been in jail multiple times, by the way. So this is a baby that a father calls me. I have a 2-month-old baby. I looked online and it looks like you have the best clinic in Texas. I don't know where you got that information. I don't see myself listed like that online. So I said, okay, where was the baby born? Oh, baby was born in Woodlands, which is up north, right? And in Woodlands, so I said, what hospital? So, anyway, there's Woodlands, one of these private hospitals there. And I called there, and they said, yeah, this baby was born here, and we talked to a physician, Texas Children's Hospital. Mother had no prenatal care, was diagnosed at delivery, okay? So the baby was at high risk, obviously, right? And they said, we talked to Texas Children's Hospital. Yeah, sure enough, they told us to give this baby 2 medicines, which is recommended for high-risk babies. And then we told them to make an appointment to that clinic. So guess what? They never made an appointment. TCH never called them. He called, for whatever reason, directly to us. And then, so while we were checking, that baby was now 2 months old. There was a 2-year-old sitting in the room. I said, what about that baby? Has that child been tested? We don't know. I said, okay, what happened? So that child, when mom was pregnant, she was in Tyler area, up, North Texas. So the dad is one of these ex-Marine guys, okay, with tattoos and all that. He's a redneck guy with anger issues and all that. So he says, I want to see that doctor, and we had a fight, and the doctor said never to come back to that office again, okay? so then we went to Arkansas, and he went to Indian reservation because the father probably has some bloodline. And the mom went into labor there and delivered there. So I said, okay, was the baby tested? We don't know. So we called that hospital. They said, well, in our reservation hospitals, we don't do any HIV testing at delivery. And there it was. That child was infected. Okay, we tested the child was infected. So anyway, we need to have good policies around proper appointments, follow through, because it's because this is, HIV unfortunately is found more often in the midst of failures, right? So we have to take into account. We cannot have natural, normal systems work for them. Anything else? How about from satellite sites? I don't know if you have any pregnant woman right now in TDC, because I think all our known ones have delivered just like last month or 2 months ago. We had about 3 this year we are following. Those who are in Houston, once they know us, they really, as long as they can drive, they want to come back and see us. If we have any pregnant woman who in TDC identifies a caregiver, before delivery, we usually call the caregiver directly, okay, and tell them we want to talk to you. Baby is going to be born. You're going to take care of it. These are the issues. But of course, we ask, does that family know about the diagnosis of HIV? And then if it's yes, then the answer is easy, right? But we run into situations where the big family members are not aware. Then we have to tell the mom that somebody's got to tell them, right? And then they come around with it. Then they make their own phone calls, call the mom or dad wherever the baby is going. We often, sometimes with their permission, we help to talk about it as well. So we have all kinds of scenarios. But if you have any tricky, difficult patients, just let us know.
So once they're diagnosed with HIV and they're disease, do they just normally say it early on if you get their entire family to consider
Yeah, yeah, yeah. That's exactly what happens. Sometimes I become aware of them in some other system, and it takes a while to bring them down to Carolina. So then I work with your social workers. I have other contacts within TDC. Usually it works well. My biggest frustration is in women, they change jail systems, right? They are sometimes in local county jail or city jail. And they get transferred to the state jail, right? Because they have HIV, literally nobody keeps them locally, right? Just because of HIV care and delivery issues. So during that time, sometimes several weeks pass by before somebody becomes aware that this is an HIV positive pregnant woman who needs prompt care. And then everybody starts to panic. That is been rather late. I'll still say that we followed enough of these babies, touch wood. Even your TDC patients haven't transmitted HIV to even one baby I'm aware of. Okay? That's good for you to know. All right. Yes, any more questions? Good question. Very good question. Nope. This is where you become smarter about how do we deal with that. It doesn't even have to go to another family. Sometimes the father knows mom, it's all kinds of weird scenarios, right? So the consent applies to an individual, right? So if mom wants to consent first, she consents for herself. She has the right to consent or refuse consent for the baby, right? Okay. But that's as long as it goes, okay? After that, we have to take over. Because we have a variety of other settings where parents refuse consent. And what do we do next? It could be patient is blood transfusion. Patient is cancer therapy. We go the legal route. And we say, this is the highest risk possible. You refuse testing for yourself, your baby has separate rights. So we have to work with that separate right theory. Even the parents have rights, it has a limit. It's not an indefinite limit. So HIV is considered potentially deadly, but also potentially treatable and preventable, right? So once all that works in your favor, you just go the normal channels, just like refusing any other thing, and we go with that. And we tell them, hey, this is not, first of all, good practice and all this. It's very rare that a woman will truly refuse the baby to be tested. Once they stare in the face of a specialist, that almost never happens. Okay? So all you have to do is try harder and talk about the alternatives and what will really happen. I've also had women who will say, I don't know, tell my husband. Sometimes a husband, sometimes a boyfriend. And, he's going to bring the child to the clinic. Don't tell him. Well, fathers have their rights too. So there are all kinds of things that we have to breach. In a family setting, we have complex situations. But each one over time, you figure out the proper ethical ground for doing things. People have, you can work with them along sensible pathway, and most people come along. All right. Maybe for another 2 years, you're okay with this topic. Okay, you're welcome. Thanks. Yeah.